Will, how are we looking out there?
We're good.
All right, great. All right, everyone. Welcome to Grand Rounds. After a little technical hitch, we're up and running again. This is today's CME code. I won't even try to pronounce that one. Today is the Ides of March, which is the 2067th anniversary of the assassination of Julius Caesar. It's also part of Brain Awareness Week, National Patient Safety Awareness Week, and National Sleep Awareness Week. That's a lot to be aware of. Will found this in honor of Mark 49 years ago at Duke. The Duke Intercom reported that the Multiple Sclerosis Society awarded a trio of grants totaling a whopping $81,000 to Duke, including a grant to Alan Roses. At the same time, somebody was using their pilot license to take a picture of the Duke campus at that time from the air. I will send that picture out to anyone who are buffs of what Duke used to look like. Oh, it was a commercial balloon pilot license. Next week, the Movement Division, Tyler's Hope Dystonia Center for Excellence, is having a symposium on Monday, March 20th. Please contact Will or scan the QR code. I guess none of you can scan it unless you do a quick screen capture, but it's going to be a very big event, coincident with the announcement of a very large grant to the group. We all have our assignments, 3 of them. The DHIP employee agreement, all of you have gotten it. It must be signed by March 31st or your checks will stop on July 1. Look for your email under Adobe Sign, one word. We're currently at 50% signing. Contact Megan if you don't think you have a signed contract or can't find it in your email. Your annual faculty assessment. This is a new policy put in place by the School of Medicine. What's due by March 15th is all faculty have to fill out their own self-assessment and send it to your division director and Pam Neville. If you don't know what I'm talking about, email Pam Neville and she will connect you up with the form. And number 3 is Doximity US News World Reporting. Please vote. Also coming next week, Janet Malik is going to talk about death by neurologic criteria, Tuesday, March 21st, and Duke's Neural Engineering Spring Series continues on next week. Our all-stars are Kelly Blessing and Giselle Lucada, nominated by Lindsay Anthony for spending 2.5 hours helping Duke Security take care of a patient, perhaps at Maureen Road. Anyway, congratulations. You're going to have a coffee cup coming. Tim Collins was in the New York Times talking about something that started with a Z, a new nasal spray. And Bill Powers was talking to the New York Times also. We're talking to the New York Times now from Duke about a thrombectomy for endovascular therapy. The research roundup, Dylan Ryan or Ryan Dillon and Wayne Fang were senior authors of a new narrative looking at medical evidence surrounding choice and timing of therapy for left atrial appendage closure. And Deborah Rose was part of an analysis of barriers and opportunities for mentoring relationships in early career neuroscientists. Congratulations, everyone. Another announcement, Megan Phillips is our new department's Chief Administrative Officer. She's been in the department longer than me. I think started here and is well deserving. And thanks to everyone who was part of the selection process, and welcome, Megan. Again, here's today's CME code, and we're going to turn it over to Kristen Veal to do today's case presentation. There you go.
Thank you. Okay, so I'm Kristen. I'm one of the MS fellows, and I'll be doing our case presentation. The microphone. Okay. So this patient is a 42-year-old female. She had a history of sarcoidosis with uveitis, and she had been on adalimumab for that. Also had diabetes and hypertension. who initially came to our clinic with a 5-month history of intermittent weakness, numbness, imbalance, and fatigue. On exam, she was noted to have 3+ reflexes in her bilateral lower extremities with cross deduction, and she had a sensory level at about T3/4. She'd actually had an MRI brain done about a year prior to presentation and done in the setting of headaches, which was completely normal at that point. This was her initial MRI brain that was done after symptom onset. And as you can see, she has several T2 hyperintense lesions, both infra and supratentorial, some in the cerebellum and brainstem, as well as the periventricular white matter that are pretty classic for demyelinating lesions. She also had an MRI of her C-spine that again showed these short segment T2 hyperintense lesions throughout the cord, some in her thoracic cord as well. So in this patient, it was thought that these demyelinating lesions were most likely related to the use of her TNF alpha blocker that she'd been on for the treatment of sarcoid. So TNF alpha blockers have been associated with CNS demyelination. There's not any clear mechanism for why this happens. There are several proposed theories, which I've kind of listed here, and it's thought to be mainly due to the fact that these are non-selective blockers of both receptor 1 and 2. TNF alpha blockers have actually been looked into for the treatment of MS. There was a couple of studies here listed that were both stopped early, basically due to dose-dependent increase in relapse rate, attack duration, and severity of exacerbations. And these trials, again, suggested that this non-selective inhibition of TNF alpha was harmful in MS, probably because it both exerts pro-inflammatory effects as well as protective effects in the CNS. So these are kind of the most common non-selective TNF alpha blockers that are used. They're used in the treatment of rheumatoid arthritis, plaque psoriasis, Behçet's, sarcoid, and inflammatory bowel disease. The first step is to stop the TNF alpha blocker and treat active demyelination as with steroids as we would if you're able. There's a lot of, well, not a lot, I'll say, there's case series, usually small numbers that talk about what happens to these patients after you stop the TNF alpha. There are many reports that patients will stabilize once you take them off the medication and they won't have any additional demyelinating lesions and they don't require long-term treatment. However, there are almost just as many when I looked of documented cases of patients having new demyelinating lesions after stopping the TNF alpha, even for months after. And these patients require long-term treatment to prevent further demyelination. And typically we're using B-cell depletion in these patients. In our patient, we stopped her TNF alpha and several months later got a repeat scan that showed new active contrast enhancing lesions. And so she was initiated on disease modifying therapy with rituximab. And that is my case.
I love a concise presentation. Love it, love it. You know, it's one of the interesting things about giving talks that you think, you know, that you have to have every detail of every point to make it a good talk, when the opposite is actually true, that people are far more likely to learn things if your talk is concise with just a couple of points. Is that right, Suma, teaching the teacher? Right. All right. All right. So it's my honor, as always, to present Mark Skeen. So I'm also a student of great talks, you know, deliveries, and Mark is always at the absolute top of the list of people who can do, you know, just deliver a stem winder. If any of you don't know what that means, we had that once at Grand Rounds. It's worth looking up. Mark is a gifted doctor as well as a gifted speaker and teacher. He's the former chief of the Division of Neuroimmunology and MS at Duke. And every year I get to look at the trainee ratings of the faculty, and Mark, as long as I've been here, is always a perfect 5 out of 5, no matter who rates him for his teaching skills. One of my favorite things about introducing Mark is, again, to show a picture of his old ship, the USS Vulcan. Mark, it was built the same year, I think. So Mark went to the University of Miami Medical School. Although you were born in New Jersey, somehow you wound up in Florida. Eventually, yeah. He did his neurology residency at Duke and then served in the US Navy, retired as a captain in 2002, and then came back to Duke. He was head of the Division of Neurology at the Portsmouth Naval Center, which is a very large medical facility. And there's Mark's ship. Is that thing still working?
No, I saved it.
The USS Vulcan. A hell of a name, though.
Yeah.
And so Mark is going to talk to us today about the future of MS care. When, in my mind, the future of MS care was in the past. When I was the age of the young people here, there was literally nothing except for steroids. And what's happened between then and now is absolutely stunning. But Mark is going to tell us there's more to come, huh?
Yeah, hopefully it's just as stunning.
Just get rid of that, go down to hide floating controls under more. There you go, hide floating.
Okay, great. Well, thanks. That's Rich put the pressure on for this now. So I'm going to talk about the future of MS care. I have a few comments to say about anybody who talks about the future of MS care. Can I advance it? What if I click? Okay. So I work with a lot of pharma companies, get paid by them for various things. If that's, there's the list. If that concerns you, I promise I won't talk much about drugs today. I'll have a little bit to say about drugs, but not a lot. So I've heard this anecdote from William Osler a lot of times and always appreciated it. Supposedly this was a quote to the graduating class at Hopkins some year. The quote is all over the internet. I couldn't find easily the date or the setting to confirm that. But it also struck me as how inappropriate it sounds to our ears today. Gentlemen, right? I mean, it just was glaring to me. So after the first word, I think it's an appropriate confession for any educator, and particularly in medicine, that probably half of what we teach is true, and we don't know which half. And it's certainly true if you're thinking about the future. It may have been true.
There were certainly women in Hopkins Medical School. It was founded in the requirement.
So there you go. It may say something about Osler himself, but we'll avoid that topic for this morning. But I think it's certainly true. I've always been impressed that futurists are foolish. They rarely get it right. And when they get it right, they never have the timing right. And particularly in medicine, I've heard some awful, foolish predictions about the future of healthcare. So if I've sufficiently lowered your expectations, I guess I can begin, as to what I think and what I hope the future of MS care looks like in the future. And I apologize for these first few slides. They're very, very wordy. But what I really want to accomplish today is for you to think about MS differently. It's not what we have thought it is. And that's why I think the future will be different. So like Rich said, we've made a huge impact in part of MS, but it's because we've only understood part of MS that the rest of it still is inadequately treated and dealt with. So we've thought of MS as an autoimmune, relapsing, inflammatory, demyelinating disease of white matter, which manifests clinically as recurrent episodes of inflammation. Our diagnostic criteria are focused on relapses. The assessments of disease activity have focused on identifying relapses, either clinically or radiographically. The efficacy of our wonderful armamentarium of disease-modifying therapies has been established largely based on what they do for limiting relapses. There's a word that's recurrent in here. We've monitored individual patients by looking for clinical and radiographic evidence of relapses. We've changed our therapies when we see evidence of relapses. So inflammatory disease activity in the form of relapses has been the focus of our diagnosis, outcome assessments, evaluating the efficacy, comparing efficacy, and choosing therapy, and monitoring therapy. And that just isn't the whole picture. And that's the message I want to get to today. This is not all about relapses. It's not about T2 lesions. It's not about GAD enhancing lesions. This is a small-minded view of MS. It's still what we do. It's what we can measure today, but it's a very small-minded view of what MS is, and it's what limits progress at the moment and limits us from really having a big impact. And that's the story I want to tell today. So most of what's going on, and most is a judgment, but most of what's going on is not seen or measured in our clinical MRIs and in the evaluations we do in clinic. So how can you adequately take care of something if you don't see it or measure it in your daily practice? So pick a year. Our understanding of MS was that genetic and environmental factors influence the development of an autoimmune central nervous system inflammation in susceptible individuals. That part is still highly likely to be accurate. The inflammation was multifocal, episodic, relapsing, was thought to be the result of cell-mediated immune responses to self-antigens targeting myelin antigens. Yeah, that's probably still true, but it's not at all the whole story. And I want to try to fill in gaps in that story today. The resultant autoimmune attack against myelin is episodic, and when severe enough, resulted in axonal loss. And that ain't it. Even when that has not much to do with episodic attacks, and it's not the severity of demyelination that causes axonal loss, and I'll try to convince you of that. Remyelination resulted in recovery from attacks. That's probably still to some degree true, but axonal injury is permanent, and repeated attacks led to long-term clinical progression due to accumulated axonal loss that occurred during attacks. No, it ain't the attacks. That's what I'm trying to tell you. Later in disease, there are fewer relapses, that's true, but ongoing progression occurred, which was thought to be neurodegenerative rather than inflammatory. Again, no, it's not that it occurs later. It's not the end result. It begins in the beginning. So it's a parallel. So we've sort of had hints of that for a long time. We've known from the earliest studies of MRI activity in MS that a lot of the MRI activity, the T2 lesions and all that I'm saying now aren't the most important thing, happened in the absence of symptoms. So there are lots, early in the disease, there are lots of radiographic relapses that are not clinical relapses. So we've known that there's stuff going on that's under the surface, if you will. We now know that CNS inflammation is constant throughout the course of MS, whether you're having relapses or not. And that's true in the relapsing and progressive forms of the disease. We also know that the inflammation is not confined to the lesions that we see on MRI scan, but it's widespread throughout white and gray matter. So this suggests that relapsing remitting nature of the disease is only a superficial or macroscopic view, and that the pathophysiologic processes are more constant and widespread. So here's what we want to start changing. So axonal loss doesn't result just from demyelinating lesions. Axonal loss occurs very early in MS. In fact, it occurs before we can make the diagnosis. It occurs in clinically isolated syndromes. More on that later. And it happens in both white matter and gray matter in the absence of identifiable lesions as we now identify them on our usual clinical MRIs. In fact, there's some evidence that the axonal loss is most extensive early. It's not the late effect of relapsing MS. It begins very early and is more widespread. And the substantial evidence suggests that when the ongoing development of axonal loss exceeds the functional compensation or the abilities of our brain, then we get permanent neurologic impairment. And that's the best predictor of what we call progressive MS clinically. But it's probably not just about axonal loss. There's inefficiency of conduction. So when central nervous system nerves are demyelinated and then remyelinated, they're never as efficient as they were in the beginning. So it's not just the axons are lost, it's the other axons that are there don't work very well. That causes increased metabolic demand and stress on the system, mitochondrial dysfunction, inadequate remyelination, and probably decreased arborization of the neurons. So even when axons are intact, they may not make as many good functional connections with other neurons. So there's a lot going on aside from just demyelination. So our understanding of MS is changing. So I want to tell you, for purposes of thinking about this, there's two types of inflammation. Type 1 is what we have thought all along, and it's this relapsing inflammatory form of MS. And I think as we talk about it, it'll be clear why type 2 looks more like what we think of as progressive MS. And probably our understanding of the disease course, relapsing remitting MS going into secondary progressive MS, it's because of a superficial view. It's a very macroscopic or clinical view of what's going on. Excuse me. It still does describe what we observe in the clinic, but if our powers of observation were better, the future of MS, we might not classify people. And I think we shouldn't classify people that same way, although there's utility there, particularly with regard to our current therapies. So type 1 is the most evident form of inflammation early in the disease. It's the result of blood-brain barrier breakdown, and that's why we have GAD-enhancing lesions. The GAD-enhancing state of an MS lesion lasts roughly 6 weeks. At the outset, at the longest, maybe 3 months, and then lesions no longer GAD-enhance. We think that's due to blood-brain barrier breakdown, where autoreactive T cells and B cells from the periphery gain access to the central nervous system, cause demyelination, and that's what we've always thought of, relapses, T2 lesions, and GAD-enhancing lesions. So I'm not here to say that's not true. I'm here to say that's not the whole story, and it's a superficial view. So the second type of inflammation is a result of accumulated T and B cells in the central nervous system in the connective tissue spaces of the brain. So we're talking about meninges, choroid plexus, Virchow-Robbins spaces. So there's a collection of inflammatory processes that once get started don't require much blood-brain barrier breakdown. It doesn't require continuing to move autoreactive cells from the periphery into the central nervous system. And that's why in those progressive forms of the disease, where this is the most prominent aspect, theoretically, we don't see GAD-enhancing lesions very often. It doesn't require that to maintain this progressive aspect. In some forms of progressive MS, we know that there are actually meningeal aggregates of B cells, and sometimes they almost look like lymph nodes. But this accumulation of resident in the CNS inflammatory cells becomes relatively independent of what's going on in the peripheral immune system. It is associated with subpeel demyelination in the cortex and diffuse injury in normal appearing white and gray matter, in a pattern that suggests a soluble or diffusive toxic influences from these meningeal and choroid sites of inflammatory cells through the white matter or gray matter that's adjacent. And we'll talk more about that. Okay. So what may not be evident is that second type of inflammation, which we haven't appreciated so much in the past. It's thought to be present from the early stages of MS, but progresses over time and becomes more evident and impactful when the more clinically obvious type 1 kind of settles down over time. So it's a matter of our powers of observation that we don't know that that's happening. It's believed that soluble inflammatory factors from B cell follicles stimulate parenchymal macrophages, microglia cells, and astrocytes. And it's those that may be some of the most significant actors in the ongoing and chronic, but more subtle inflammation in the central nervous system. It results in demyelination and neuronal injury via oxidative damage. And as I mentioned before, it's not just about the loss of axons. It could be arborization, oxidative stress, decreased arborization, a lot of things that make CNS neurons not work so well. So this is my last really lots of text slide. I apologize for these. So I'm telling you this story first. I'll show you some data, but I wanted to set the stage. So our understanding of that type 1 inflammation has been of tremendous benefit. Like Rich said, since I've been a physician, MS has changed dramatically. We kind of got type 1 inflammation down, frankly. With our high efficacy therapies, we pretty much stop it. And we have a lot of patients in clinic who go year after year after year, despite the relapsing remitting nature of their disease, who don't have a lot of or any relapsing remitting disease that's evident. So we kind of got type 1 down, and that may be an exaggeration, but for those of us that have been doing it a long time, we can feel that difference in the clinic between our high efficacy therapies and stuff that was much less high efficacy in the past. But all of those therapies are most effective early in the disease when the disease is highly relapsing remitting, or at least that's our perspective of the disease. They're much less effective later when perhaps type 2 inflammation becomes the more dominant aspect of MS. And for the most part, we haven't been able to show that those drugs actually work once relapsing disease does not characterize the patient's disease. And so the yet unmet need in multiple sclerosis is to clarify all this stuff I'm going to talk about type 2 inflammation, try to understand it, try to have an impact there. And as we do, we really need to change how we measure MS, how we treat it. And the start of that is what I'm trying to give you as a different perspective on what MS is. So there's a couple of clues from genetics. This is a slide that shows genes that have been linked to MS. I apologize, I am not technologically savvy enough to move a slide I saw from a great presentation into my slides. It's on my cell phone, it'll be there forever, but I couldn't put it in PowerPoint. But the point is there's a whole lot of genes that can influence the development of MS. And if you look at what most of those genes are, they mostly have to do with the immune system. Surprise, surprise, right? However, some recent research has looked not at just who gets MS, but who has severe MS. And guess what? Most of the genes that are tied with MS severity have to do with CNS genes, not inflammatory genes. And a lot of them have to do with microglia. So there's a key that, yes, this is an immune problem, but maybe the severity isn't so much about which immune gene you get. Maybe it has to do with how your brain functions, interacts, responds to that initial insult. So to me, that was an eye-opener. When I saw this presentation, it was like, oh my goodness. Even when we look at genetic susceptibility to types of disease, and it was severity, it wasn't progression, but it was looking at people who had really bad MS clinically. Then we start to see that a lot of the genes that seem to correlate with that severity are really CNS genes. So this is kind of an op-ed piece talking about that the smouldering, that's what it is. In Great Britain, it's smouldering. Here it's smoldering. We leave out the U, right? But it's that smoldering MS is the real problem. And that's what I'm trying to tell you today. So I'm going to talk about a couple things. It's quick. It's not going to be thorough, but I want to give you a taste of what are we talking about here. The first thing I'm going to talk about are recent observations that even in relapsing remitting patients, progression occurs in the absence of relapses frequently. That's a paradigm breaker for many of us in the clinic. It's not once they've had relapsing remitting MS for 15 years, it doesn't surprise us that we see progression. But what I'm going to show you are a couple of studies that say no. When we retrospectively look at data from clinical trials, we see that even in early relapsing and remitting MS, there's progression. I'll define progression for you. even early in MS. So progression in MS, it's an operational definition. So we examine people, do the neurologic exam. There's scores that go with each section. It's called the EDSS. It adds up. It's not a very good scale. For reasons that baffle me, we continue to use that as our main outcome measure for clinical trials, for phase 3 clinical trials in MS. I'm going to talk a little bit later about, we got better things we could do, but anyway, that's our scale. So in the course of a clinical trial, if somebody goes up a point or two, or however many on the EDSS, that says their function, their neuroexam has changed. And we've defined a relapse as when that goes up but comes back down, that's a relapse. But if it goes up and stays up, we call that progression. So that's kind of like a clinical trial operational definition of relapse versus progression. So they went back and looked at a couple of clinical trials. I'll show you those, and realized, gee, even early in MS, sometimes we see progression in the absence of any radiographic or clinical sign of a relapse. So maybe that's a change in how we think of things. I'm going to show you some stuff about gray matter pathology, trying to convince you this is not just demyelination, or at least not just white matter demyelination. I'm going to talk about what I would call a new concept of chronic active lesions. I'm going to talk a little bit about meningeal inflammation and choroid plexus. And then at the very end, I'll try to say, well, what does all this mean and what do we do about it? So I apologize that the title is okay. So this is a look, this is what I was just talking about, a retrospective look at clinical trial data in which they just looked at patients who had progression defined as a sustained increase in EDSS through the course of a clinical trial. And did it occur at the time of a clinical or radiographic relapse? And the answer was frequently it was separate from clinical or radiographic relapses. Yeah, I'm having trouble advancing again. Let's see here. Touch this slide. Okay. Okay. This is similar data looking retrospectively at the relapsing remitting trials of ocrelizumab compared to beta interferon 1A, 2 trials called Oratorio, and they did the same thing. They looked at through the course of those trials, these are relapsing remitting trials, how often did the EDSS increase from visit to visit and maintain an increase in the absence of what we would define as a relapse clinically. And it was a significant number. One of these, the number was 25% of the time when the EDSS increased. It was in the absence of anything we would recognize as a clinical relapse. This is another look at the same thing, just making the case that not in progressive MS, but in relapsing remitting MS, there's a significant amount of progression independent of relapse activity. So that's the new catchphrase for what we're talking about here. I showed you 3 slides. If you Google MS progression independent of relapse activity, the literature is just all over the place. There's a lot of it. So in the past, pathologically, we've been aware of cortical lesions, but we haven't understood their significance. Now we know with fancy MRI techniques, not our routine techniques, that many people have cortical lesions in MS. Some of that's early. And when we look at that, we see that the number or extent of cortical lesions has a lot to do with what we call progression of disability and multiple sclerosis. This was a look at CIS, this looking at atrophy in deep gray matter, primarily the thalamus and in the cortex. And they looked at healthy controls compared to patients who had a single demyelinating lesion. And if you looked at the whole group of CIS patients, there wasn't much difference in those gray matter volumes. But if you looked at, let's see, those who eventually progressed to MS, even in the very beginning, they had decreased thalamic volume and decreased cortical volumes. So even before we can make a diagnosis of MS, those people who do go on to MS have signs of gray matter pathology before they've had enough clinical relapses or MRI findings in our usual measurements of MRI to make the diagnosis. Another look at thalamic atrophy and just saying that it's associated with increased cognitive impairment. Cognitive impairment is a big problem in MS. Folks are not demented, but they have significant speed of processing issues primarily that really impact often employment and function, particularly in the setting of multitasking. This is a look at just using, thalamic volumetric measurements and what happens to them over time and how that correlates with disability. And this was a study trying to show that we could actually use measurements of thalamic atrophy over time as a biomarker of disease progression. So that's not at all in common use. I'll say when we think of gray matter atrophy in MS, we particularly notice thalamic atrophy early or from the beginning, and later in the disease, what appears to be atrophying the most is cortical areas. Although that data is a little, I would say there's a consensus about that, even though it's not absolutely documented. This is a study that looked at gray matter volume loss, correlating it with the degree of disability, and suggesting that if we think of MS as a white matter disease, we really are not measuring the aspects of the disease that best correlate with disability. I want to talk a little bit about chronic active lesions. When I first heard the term, it was a paradigm breaker, so I didn't like it. I don't like my paradigms to be broken, right? These are not chronic active lesions in the way you would think that they enhance for a long time. We don't see that. If we see a chronically enhancing lesion, it's probably a DVM or something else. It's probably not a demyelinating lesion. And when the radiology report says there might be a little enlargement of a T2 lesion, I always say, blah, I don't think so. And then I look at it and I usually convince myself it's not really enlarging. So when we say chronic active lesions, these are not things, I would argue, that we see in clinic with our current MRI scans. On the other hand, there's now a huge literature talking about chronic active lesions, slowly expanding lesions, and paramagnetic rim lesions. All of these are identifiable by more sophisticated MRI techniques than we use in the clinic. And what has evolved is this understanding that those T2 lesions that we see that are no longer enhancing, some of those still have quite a bit of inflammation going on, and at least microscopically they are enhancing. And there is associated axonal loss in those lesions that is progressive over time. And so a huge amount of literature is trying to figure out what does that mean? But the number of chronic active lesions, paramagnetic rim lesions, slowly expanding lesions, is associated with worse outcome. So it doesn't appear to be just something of observational interest. It appears that this is, at least correlates with the degree of progressive impairment over time. And if you look in those lesions pathologically, so what they did is look at paramagnetic rim lesions and look pathologically at what's going on at the rim where this iron deposition is. You see a lot of microglia and astrocytes that are active in that area of axonal loss. And when you look at what's going on, those microglia that are there have a particularly inflammatory or neurodegenerative gene expression pattern. So there's stuff going on in these chronic active lesions although there could be lymphocytes and all there too, what's going on may be largely dependent on CNS resident cells that are now tuned to do destruction. And I'll talk more about that. So I mentioned this, that chronic active lesions are common and they're associated with more aggressive disease. There's ongoing tissue damage. And this is true even on some of our patients that are on even potent therapies for what we've called type 1 inflammation. So I'm trying to tell you a story. I hope you're starting to buy it. But this starts to suggest that maybe we need to measure things differently, think of things differently, and hopefully treat things differently. So I sort of already mentioned this, but that cortical lesion load has also been associated with cognitive impairment and progressive disability over time. This is relatively newer, looking at choroid plexus pathology. So if you measure the volume of choroid plexus, I have never noticed the difference in anybody's choroid plexus, I don't think. But if you measure choroid plexus volume, folks with MS, it's frequently larger. The impression, I'll say, is that that's because of inflammatory infiltrates. And we now are starting to see some data to suggest that those folks who early on have larger choroid plexi, I guess is this plural, that's also associated with progressive disease over time. So I slammed up a bunch of, if you look up MS and gradient pathology, there's a lot of literature, and I've just put several up there. But so the picture that's evolving is that from a very early time, it's more obvious, particularly in secondary progressive MS, but probably from a very early time, once autoreactive T cells and B cells gain entrance to the central nervous system, there is this collection of innate immune cells and adaptive immune cells. So B cells, T cells, adaptive immune system, innate microglia, and even astrocytes that are in the meninges, in the choroid plexus, in the Virchow-Robin spaces. And then when you look pathologically, what you see is progressive axonal loss and demyelination right next to those areas. And there's, as you follow that inward, away from those areas of meningeal inflammation or perivascular inflammation, it's less. So there's this gradient effect that's nearby where these rests, if you will, of innate and adaptive immune cells are. So the idea that there may be some soluble influence. It wouldn't have to be soluble, but migrating through tissues doesn't happen a lot. So there's probably some kind of soluble influence that determines how much demyelination and axonal loss is going on. So a lot being written about that and try to figure out what is that process. So I've got a bunch of slides about microglia here. I am not an expert whatsoever in microglia. When I was a medical student, I was taught that microglia played a supportive role. What's that, to fill the skull? I mean, yeah, I was told they were macrophages, and I'm thinking, how come we need so many macrophages in the brain? You know, what the heck? What's getting gobbled up in the brain? Anyway, that was kind of the state of my understanding of microglia. It's still very primitive, but these topics have inspired my interest, I'll say. So what we see, and this is a sort of authoritative look at what we think might be going on, is this lymphocyte microglia astrocyte axis in these chronic active lesions of multiple sclerosis. I'm not going to spend too much time. Well, I'll read what's here. So I mentioned that in the edges of these chronic active lesions, we see microglia and astrocytes that appear to be associated with ongoing damage and progressive disease. We know that those macrophages, so macrophages in my primitive understanding, are resident cells. They have a lot to do with neurogenesis and synaptic pruning and things, but they are very reactive to their individual localized CNS environment, and they change transcriptionally depending on their environment. And one of the ways they change transcriptionally is to be stimulated into what these authors called microglia inflamed in MS, a particularly genetic transcription profile. And that profile overlaps with the transcriptive pattern that microglia have in very many neurodegenerative diseases. So there is something about how the immune system changes microglia that makes them look like microglia in other neurodegenerative diseases. The fourth or fifth bullet here, it talks about oligodendrocytes. When we look at MS, we also know that we've probably got enough oligodendrocytes present in MS lesions to promote remyelination, but the oligodendrocytes don't seem to work right. They just don't do a good job of remyelination. So when we think about, putting stem cells where they need to be, a lot of people have talked about putting extra stem cells into the brain and turning them into oligodendrocytes. It's all well and good, but it doesn't appear that there's a problem with not having enough oligodendrocytes. It appears that they don't work very well. Well, that might be an influence of microglia whose transcription patterns have changed. The oligodendrocytes might be there, but there's evidence that they influence the oligodendrocyte function. I'm going to go faster through some of these. So apparently, I didn't chase this at all. This was from that article, that there is a rare monogenetic autosomal dominant form of microgliopathy. And in that condition, there's diffuse demyelination, astrocyte activation, and neuronal injury. So just to say that microglial pathology can do, under certain circumstances, a lot of the things that are going on in MS, and that pathogenic T cells secrete a granulocyte macrophage colony stimulating factor, and that microglia respond to that, as do oligodendrocytes. I think I don't want to act like I know more about microglia than I do, which is not very much. I wanted to talk very briefly about our therapies, and this is all speculative. So we have 4 now S1P modulators FDA approved to treat relapsing forms of multiple sclerosis, including active secondary progressive multiple sclerosis. Since the very beginning, we hoped that fingolimod, the mechanism of action of S1P modulators is thought to be that it sequesters lymphocytes in lymph nodes. So you have very few circulating lymphocytes, and they're quite effective in stopping type 1 inflammation. Maybe not quite as effective as some of our other IV therapies and all, but they're pretty potent medicines. But from the very beginning, we've wondered whether S1P modulators had a direct effect in the brain. Why would we wonder that? Well, there are 5 S1P receptor subtypes. There are S1P receptors on most of the CNS cell types, different receptor subtypes. The amount of S1P in the brain is highly regulated in terms of how it's formed and how it's degraded. It's, very tightly controlled, probably meaning it's not an accident, that there are S1P receptors there and that there's S1P there. Understanding what roles they play is very complicated. They apparently play different roles in a young brain versus an older brain. They play different roles seemingly on different cell types. They play different roles in mice than in men. So it's pretty complicated to understand it. And frankly, we don't. But we've hoped that maybe there was a direct central nervous system effect that was of advantage in the S1P modulators over just treating the immune system. We've hoped. There's always been good data regarding preventing atrophy or or reducing the degree of CNS atrophy from the very early on. Enough so the drug companies tried to get the FDA to include it in the package insert, and they were not willing to. But then with fingolimod, we did a primary progressive trial, which was an abject failure. It was a well-done trial. It was at the investigator meeting when the data was presented. It was the most depressing investigator meeting I've ever been at. Usually you can, when a trial's done, you can say, well, if we'd have done this, here, look at this subset. If we'd have done this, we'd have seen about, there was nothing. There was no way to turn anything from that primary progressive trial of fingolimod into something positive. Everybody walked out of the room, shoulders down. It was just depressing. That seemed to be the end to this idea that maybe S1P modulators are doing something in the brain. There's also, not all S1P modulators get into the brain very well. That's a separate issue. And then I pulled this largest graph here from the package insert for siponimod. So siponimod was, if you will, an evolution of fingolimod, which mostly eliminated the S1P3 receptor binding. And the company decided to do a clinical trial in secondary progressive MS. And this is data from that. This is a subset analysis. And I want to show you something about it. So the trial was positive. It showed a benefit in secondary progressive MS. When the FDA looked at the data, and I'll show it to you here, they concluded, well, the drug worked in active secondary progressive MS, meaning lesions, relapses, T2, right? GAD-enhancing lesions. But we're not sure that it worked in the absence of this. And so the FDA made their own classification and said, we'll approve it for active secondary progressive MS. And then the FDA gave all the other drugs that work in relapsing MS the same indication. They all work for relapsing forms, including secondary progressive with relapses. We still don't have a drug that's been approved for secondary progressive, if you will, if you don't have relapses. It's all well and good. I was astounded, frankly, because the trial was designed just like every other secondary progressive trial had been. And when you look at this subset analysis, so I don't know if you can see this very well, but this is looking at various subsets. So if you look at people who had superimposed relapses within the 3 years prior to the study, here's a line favoring placebo is to the right, favoring the drug is to the left. If you look at people who did not have relapses versus people who had relapses, the people with relapses had a more profound effect, more profound benefit. If you looked at people who had relapses during study, those who had relapses during the study also had a more profound benefit than those who did not. Gender wasn't much different. If you look at people that had gadolinium-enhancing lesions at baseline entry to the study, those who had gadolinium-enhancing lesions had a much better response to the drug than those who did not at study entry. If you look at baseline age, the older you were, the less benefit you got, okay? And if you look at EDSS, the higher EDSS is worse. I mean, there's just a clear indication there that the higher your EDSS is, the less the drug does. Well, duh, right? We know these drugs are profoundly effective for type 1 inflammation. I mean, to me, that's a no-brainer. To me, what impressed me is that even if we look at the people who did not have a relapse, it's not statistically significant, but it favors the drug. Even if we look at people who didn't have relapses during the study, it favors the drug. Even if we look at people who didn't have GAD-enhancing lesions, it looks like it favored the drug. Even if we look at people 60 years old, it favors the drug. And even if we look at people with EDSS of 6 who need some assistance for walking, it favors the drug. Now, those weren't statistically significant. To me, this looks like we could do that trial now and power it different. It looks that way to me, that we could show that this drug does something, even in the absence of type 1 inflammation. It's complete speculation. We don't know. We don't have the data. It wasn't powered that way. It still leaves me a little hope that we are having an impact on what we look at as progressive disease and calling type 2 inflammation with S1P modulators, but we don't know. So the next big hope in MS is our BTK inhibitors. I'm running out of time. It's okay, we're close. BTK inhibitors are a new class of drugs. Our excitement over them is, yes, they look like they will probably work in type 1 inflammation, but because they have very significant effects on microglia and perhaps to a lesser extent astrocytes, maybe they will also be a next big leap forward, and maybe they will treat type 2 inflammation as well. So I am running out of time, but I wanted to mention that we need to measure MS differently. So the SDMT is this test, this is just one example of things we could measure. SDMT is this test where people are given a key here of symbols and numbers, and they look at the symbol, they find it, they write the number below it, and they keep going. And that's all the SDMT is. It's how many of these you can do in 90 seconds. It's a very easy to administer test that correlates well with the cognitive impairments that we see in MS. We have a defined decline that's clinically meaningful and correlates with other dysfunction. It's a good predictor of ADLs and employability, et cetera. It's a very easy way to monitor something that is important to patients that we could do on a regular basis at every visit, wouldn't require us to do it. And there's lots of evidence that it would also help us measure clinically, rather than just the neuroexam and EDSS, a task that will find more subtle trouble. And it's one example of measuring cognition. There are some other things we could measure and this article talks about other measures that we can use in clinical trials and in the clinic in order to better measure MS rather than all about EDSS or neuroexam and white spots on MRIs. So what does the future of MS look like? Number one, we need to change how we think about it. It's not how we've imagined MS to be in the past. We need to change how we measure it. I haven't talked about biomarkers and everything. There's a lot of other things that we could include in here of things that may allow us to measure stuff that's not type 1 inflammation and get at the heart in both clinical trials and in the practice. And then we need to ultimately change how we treat it. Maybe we should be measuring, progression independent of relapses in our clinical trials as a primary outcome measure rather than just relapse associated disability. What are the challenges? Well, we're talking about a lot of surrogate markers. And so our confidence in what they mean will remain obscure. I think we're going to have to depend on surrogate markers because in early relapsing remitting MS, it's hard to measure the clinical part. We might some with SDMT, et cetera, but stuff that takes a long time to show up clinically is going to be hard to do clinical trials with only clinical outcome measures. It's probably going to be a long time before we have comparative trials amongst the different MS drugs and any of these surrogate markers. We're probably going to have to convince radiology and a bunch of other people and the payers and the regulators that this stuff is important. So we're going to have to believe it, and we're going to have to get some buy-in. And then we're going to have to re-educate our patients because we've taught our patients all about the problem with white spots. And we're going to have to re-educate them as well. So I didn't leave much time, but I will take any questions.
I would say since we've got a crowd outside, anyone just grab, we'll have Mark and
And could you repeat the question so people can hear in the audience?
Yeah, so we're going to actually not take questions here. I'll answer them at some other time, just because we got people waiting.
Sorry. Yeah.
Good.
You're such a gifted speaker. I was looking up why this thing keeps coming back. It's a thing on the internet. I got to book this room from 8 to 10, so people.
Or at least 9:30.
I don't think they do 30s.
Yeah. Yeah.